Warm good morning, my dear students. We were dealing with the different diseases of bone, and in the last class we had discussed on the classification of different types or different diseases which affect the bone, and we looked at a separate entity or a group of disease which was called as fibro-osseous lesions. That is basically the normal bone gets converted to fibrous tissue. So entire normal bone is replaced by a fibrous connective tissue. So you have a fibrous component as well as an osseous component, and the osseous component that is produced is actually not proper bone. It is mainly immature bone or a woven bone, and because of that the entire bone becomes weakened. And under fibro-osseous lesions we had classified it into three, and we discussed on fibrous dysplasia. So fibrous dysplasia is a type of fibro-osseous lesion wherein you have the entire bone being replaced by connective tissue. And we have also gone through the different types of fibrous dysplasia, that is monostotic, polyostotic. Polyostotic is further divided into your Jaffe-Leichenstein and your McCune-Albright syndrome, and we also have the craniofacial form. So this was what we had dealt under fibrous dysplasia. And in today's session, we'll discuss on cherubism and the remaining fibro-osseous lesion, that is cementosseous dysplasia. Now, cherubism was initially considered to be a type of fibrous dysplasia. And in today's literature, it is no longer a type of fibrous dysplasia. It is considered as a separate entity. So, cherubism is otherwise called as familial fibrous dysplasia. Now, familial fibrous dysplasia, initially I told you it was considered under fibrous dysplasia or a type of fibrous dysplasia, but no longer it is considered as a type of fibrous dysplasia. It is a fibro-osseous lesion which is autosomal dominant. So it's basically a developmental disease of bone. It's also hereditary and it is a non-neoplastic condition. Now, why the word cherubism? How is it the terminology is obtained? Now, it's basically because of the facial appearance, and it's similar to the plum-cheeked little angels, which we call as a cherub. So, the appearance of a cherubism patient, a patient with cherubism, will look like your cherub because of the swollen cheeks or the plum cheeks. When you look at it, males, it is more predominant, so it has 100, since it's a hereditary disease, there is 100% penetrance in the males rather than the females, and the females is affected is between 50 to 60%, so more predominant for the male patients. When you look at the etiology, it's again a mutation which is occurring. Now the mutation is basically occurring with the autosomal dominant gene, so basically the non-sex linked genes, which is going to be related to the development of the jaw. So this gene which is affected here is the one which brings about the development of the jaw. So this gene is located to the 4th chromosome, that is in the P arm, and it's called as the SH3BP2 gene. So the gene that is involved here is SH3BP2 gene. Now this gene is the one which transmits chemical signals within the cells for the bone remodeling in certain immune cells. So it has, or the gene codes for signals for bone remodeling as well as some kind of immunity cells. Now an increased expression of the gene, so an overexpression of the gene will lead to overactivity, and this overactivity will produce inflammation of the jawbone because it is related to your immune cells as well as cells for remodeling, bone remodeling. So now hyperactivity of the gene or overexpression of the gene is going to produce inflammation of the jawbones. It will trigger the production of the osteoclast and cause breakage of the bone while remodeling. So this is basically what is happening here. There is inflammation, excess inflammation, and the excessive inflammation will trigger the osteoclast production. So osteoclast will be more, and since osteoclast is more, there is so much of bone resorption happening. So it will cause breakage of the bone or resorption of the bone when it is undergoing remodeling. So both these together, both these processes together, that is, you have an inflammatory process co-added with bone destruction or bone lysis or resorption of bone. So these two together will produce cystic lesions within the jawbone. So it is mainly present to the localized to the tooth-bearing area or to the jaw bones. And since you have two processes happening within the disease because of hyperactivity of your SH3BP2 gene, you have inflammation as well as bone resorption, and that will lead to a lot of cystic space within the jaw. And now this again, since it's a developmental disease, it is related, it will be manifesting in children, and just like your fibrous dysplasia, it is going to undergo remission by puberty. So by puberty, when the growth of the jawbone ceases or growth of the person ceases, skeletal growth basically, again this disease will regress by itself or it will subside by itself. And here what happens is, by puberty, because there is an increased estrogen level, that will lead to reduction in the osteoclast level. So there is a hormonal change that is happening during puberty. The hormones for bone growth will be more by puberty level. So estrogen will be more, and that will lead to a decreased amount of osteoclast. So by puberty, the entire disease is going to regress. Looking at the clinical features, so most common, the average age group is between 2 to 5 years. So it will usually start, the disease will start not at birth, it will be after birth, around approximately between 2.5 years. And by 5 years, the entire disease will be expressed. It will grow slowly, progress slowly till the puberty time period, and then after that it's going to stabilize itself. So once the person has attained puberty, it will be stabilized, and after puberty or just after puberty, it's going to regress. So by the age of 12 to 15 years in the teenage life, this disease will regress. Affected children, when born during the birth, they appear normal. So at birth, the child is going to look normal only. It's only after 2 years such a clinical presentation will start appearing. Now the site is mainly your mandible, so more common to the posterior mandible, and it's basically a bilateral involvement. So that is why it looks like plumpy cheeks on both sides, or it has an appearance to the cherub. So it has a bilateral involvement which will give the appearance of chubby cheeks. Another feature which is common to these patients are, you will have a typical appearance of a cherub. Now if you observe the cherub, the eyes of the cherub will be turned upwards. So here again, in this patient, you have upward turning of the eye. So it looks as if the eye is turned towards the heaven. So eye turned towards heaven appearance is present for cherubism. That is because of the inversion of infraorbital rim and the orbital flow, exposing the sclera below the iris. So this part is going to get inverted inwards. So the sclera will get exposed and it look as if the eye is going to be facing upwards. Other features which you can see along with the chubbiness of the jaws or the cheeks, you can have cervical lymphadenopathy. Since it's an inflammatory disorder, there is some amount of inflammation, or basically inflammation happening within the disease. So you will have lymphadenopathy, especially the cervical lymph nodes. Then respiratory obstruction, because the jaw bones are swollen up. There is swelling or expansion of the jaw bones, so breathing difficulty will be present. The eyes are being affected, so there is impairment of the vision as well as hearing. And also, since the bone is being resorbed, there will be difficulty in mastication due to loosening of the teeth. And also the jaws are expanded. So because of that, mastication and the occlusion gets altered, mastication becomes really difficult. The oral manifestations which you can find in this disease is overgrowth of the mandible and the maxilla. It is a symmetric disease which involves both the jaws. So that is both left and right will be affected. So symmetric, it's asymptomatic. So painless jaw lesions. Most common site is the mandible, and also the molar area, that is the molar and the coronoid region is the most common site which is affected. When it affects the maxillary arch or the maxillary bone, the palate becomes V-shaped because of the swelling or expansion of your maxilla. The palate inside will become V-shaped. And also you have widening and distortion of the alveolar ridges. So the ridges or the alveolar jawbone gets distorted as well as widened. Since there is resorption of bone, you will have tooth displacement, and also because of the expanding jawbone, there will be displacement of the teeth. Failure of eruption of your mandibular molars, especially the second and the third one. Premature exfoliation of the deciduous dentition because there will be mobility, and this disease will manifest at a younger age group, that is between 2 to 5 years. And severe cases, tooth resorptions can also be seen. You have certain syndromes associated with cherubism, so that is neurofibromatosis type 1, Noonan syndrome, or otherwise called as a multiple giant cell lesion syndrome, Raman syndrome, and Jeffrey syndrome. Now, Noonan syndrome is the one which is mainly commonly associated with cherubism. Now, here you will get lesions in the humeral region or humerus. Along with that, you will get gingival enlargement. So, you will have gingival fibromatosis, psychomotor retardation, orbital involvement, and obstructive sleep apnea. So these are some features or characteristics or clinical presentations related to Noonan syndrome. So you get a lot of expansile or cystic lesions within the humerus area, gingival enlargement, which we call as gingival fibromatosis, retardation of psychomotor area, that is psychological problems will be present, orbital involvement, and also sleep apnea. Raman syndrome is again cherubism with gingival hyperplasia. So again gingival fibromatosis. You have seizures, slow mental retardation, and this mental retardation will start at the age of 10 years. So these are different features which are common to both these syndromes. Cherubism can be graded based on the involvement of the bone. So it could be related to maxillary or mandible involvement. So based on the different involvement of the bone, it can be graded from 1 to 5. Now grade 1 is if it involves only the mandible ascending rami. So ascending ramus of the mandible without root resorption. Grade 2 is ascending rami along with maxillary tuberosity. So you have maxillary tuberosity being added without root resorption. Grade 3 is aggressive. It's more aggressive. And you have another thing which is different from the first two grades, that is root resorption. So root resorption is going to be present in grade 3. Grade 4, it's more aggressive. So both the jaws are going to be involved along with root resorption. Grade 5 is severe form of cherubism. It's massive, it is more aggressive, more deforming, and it's mainly common to the juvenile area, which involves both maxilla, mandible, and also the coronoid and the condylar area. So entire mandible is going to be affected, maxilla is going to be affected, and it is the severest form of your cherubism. So this is the way the grade grows. So grade 1 is just ascending rami without root resorption. Grade 2 is ascending rami with maxillary tuberosity without resorption. Grade 3 is involvement of mandible with resorption. Grade 4 is both mandible and maxilla with resorption. And grade 5 is the entire jawbone is going to be involved. So this is just a pictorial representation having grade 1, grade 2, grade 3 and all. So if you observe grade 1, it's only related to the ascending rami. So here you will have cystic lesions or lytic lesions. So only the rami is going to be involved of the mandible. Grade 2 is where you have the maxillary tuberosity, that is this region, along with the ascending rami. Grade 3 is a severe involvement. It is aggressive. You have the entire thing. So grade 3 and above, you will see the entire maxilla. So this becomes grade 5 actually. If it is grade 5, you have involvement of the coronoid and the condylar area also. So grade 3 is without condyles. Without condyles, and coronoid area is grade 3. Grade 4. Grade 5 is the entire bone with coronoid area. So As the grade increases, you have the entire maxilla and mandible being affected. So it is similar to McCune-Albright syndrome involvement of whole maxilla and mandible except coronoid process and condyle. So this is a grading which was given by Arnott in 1978. Moving on to the radiographic features of cherubism. Now this is a multilocular radiolucency. It is a cystic lesion which you're going to get. So it is a multilocular expansile radiolucency which is present bilaterally. So both the jaws are going to be affected. The earlier lesions are present towards the ascending rami and the posterior body of the mandible. There is evidence or there is presence of numerous unerupted teeth. Destruction of the alveolar bone. So you have lytic lesions of the alveolar jaw bone that will lead to destruction of your interseptal bone and the bone which is present basically between the different teeth. So that will that will destroy the entire alveolar bone, and it will appear as if the tooth is floating in air, because that area of the bone, that entire area of the bone is going to be destroyed. So there is no bony support for the teeth, and it looks as if, or it will give an appearance of floating tooth appearance. So floating tooth. So if you observe this picture here, you can see the entire bone here in this area is resorbed, and it looks like as if the tooth is floating in air or hanging in air. So you can have an appearance of floating tooth, that is because of the destruction of your alveolar bone. Another appearance which you can get, which is similar to fibrous dysplasia, is your ground glass appearance. So that is during adulthood. So when the person reaches adulthood and the disease is going to regress. So during that time, when the jaws start to reossify, you will get irregular patchy deposits of bone or patchy sclerosis. So that will give you a ground glass appearance. So these are the different things or radiographic findings in cherubism. It's basically a cystic lesion. So because of that, you have a multilocular expansile radiolucency. Now if you observe here, this is what you're seeing. A lot of cystic spaces, a lot of multilocular areas, which is radiolucent. And unerupted teeth is going to be present. There is destruction of alveolar bone, giving an appearance of floating tooth. And by adulthood, it becomes ground glass appearance because there is regression of the lesion and the jaws will start to reossify, forming patchy deposits of bone. So that will give you this appearance. Histopathology, when seen, there is presence of lot of osteoclast-like cells. We know that it is a lytic lesion. So within the histopathology, you're going to see a connective tissue background with less amount of bone deposition, and you will see a lot of osteoclast-like cells, or basically to say multinucleated giant cells. So what you're seeing are multinucleated giant cells. So it has a similar resemblance to your giant cell granuloma. So it resembles, or it has more appearance to a giant cell granuloma. And when you see the background connective tissue, the connective tissue is loosely arranged and it will have a waterlogged appearance since it's loosely arranged and a lot of spaces are present and it looks swollen up. So as if there is waterlogging within the connective tissue. So it will have a waterlogged appearance. Presence of numerous multinucleated giant cells, and these giant cells are basically small and they aggregate focally. So within areas focally you will find them very close to each other. Another feature which is seen is eosinophilic cuffing. That is eosinophilic or pink colored deposit surrounding the blood vessel. This is what you see in this picture. You have a eosinophilic or a pink color deposit which is going to be surrounding the blood vessel, and this is called as eosinophilic cuffing because it will be like a cuff around the blood vessels. And in older lesions, there will be fibrosis, there will be reduction in the number of giant cells and also new bone formation because the lesion is going to regress. So obviously the clastic destruction of the bone or resorption of the bone will decrease. So you will have reduction in the number of giant cells. There will be a better connective tissue being formed. So you have dense collagen fibers and also new bone formation. Treatment, no treatment is required. So by puberty, the expansion of the jaw is going to cease and it's undergo it will undergo resolution. Now, in case if it doesn't undergo resolution, surgery can be performed for cosmetic application. So, to increase the aesthetic effect, you can do surgery. So, otherwise, as such, cherubism does not require any treatment. The next category is of fibrosis lesion is cemento-osseous dysplasia. Now, this is one of the most commonest fibrosis lesions which occurs within the jaw, and this is common to tooth-bearing area. So, very common to your alveolar bone. And here, what you're going to see is cemento-osseous dysplasia. Dysplasia means abnormal growth, and within this, you can see cementum-like deposits and bone-like deposits. So, this is what you're going to see within the lesion. So basically more of it forms cementum-like material or deposits within that area. Very common to the periapical region, especially associated with the periodontal ligament space, or it has approximation with the periodontal ligament. Now when you look at the origin for cemento-osseous dysplasia, it has a lot of controversies. So it could originate from the periodontal ligament, or it could be because of some derangement in the bone remodeling area, or there is a defect in the extraligamentary bone remodeling which is going to be triggered by the local factors, or it could be because of hormonal imbalance. There are different types based on the radiographic features. So you can have a periapical type which is present in the periapical region, a focal type which is localized to single tooth, and another type which is called as a florid cemento-osseous dysplasia. So three varieties based on the radiographic pattern: periapical, focal and florid. So we'll go on to focal cemento-osseous dysplasia. Now this is common between 3rd to 6th decade. Very common to the females. So it is 90% and most of the females are going to be commonly affected. Since it's focal, it is single site involvement. That is why the word focal is used, because only a single area is going to be affected, and it can be any jaw area. So any part of the jaw you can get, but only a single area is going to be involved. More common to the posterior mandible. Clinical features, it's more of asymptomatic lesion. So whatever we've been studying now, it's more of asymptomatic. And here you have formation of cementum-like deposit which is less than 1.5 centimeter diameter. So it's a very small size swelling. Radiographically, when you see, it's well defined and it's completely radiolucent to radio-opaque lesions within a thin peripheral radiolucent rim. So if you observe here, see, this is a radio-opaque area, and surrounding the radio-opaque area you see a thin radiolucent rim or peripheral rimming, radiolucent peripheral rimming you can see, and it's well circumscribed. It's a well-defined lesion. Now sometimes you can have a complete radiolucent area also, not necessarily you will see the radiopacity. It will be just a radiolucent area, and more commonly the pattern that you're going to get is both radiolucency or radiopacity, like this. So you can get a mixed pattern with radiopacity surrounded by radiolucency. Again here you can see it's radiopacity more, and this is more seen in extraction site. So if you observe this radiograph here, this is related to an extraction site. So very common to extraction site. So this is what you see. It is morely asymptomatic with a swelling which is less than 1.5 centimeters, and it's more a radiographic finding. So you can see well-defined complete radiolucency or opacity or a mixed pattern, and more common to your extraction socket or extraction areas. So in this session we had discussed on cherubism. We completed one type of fibrosis lesion. The other one which is actually there is your cemento-osseous dysplasia. So we have discussed only on a portion of cemento-osseous dysplasia, that is basically the focal type. And in the next session we'll discuss on the other two types, that is periapical type and as well as the florid type. So the questions which can be asked related to this session, cherubism, can be asked for 5 marks, and also osseous dysplasias can be asked for 5 marks. Thank you and have a good day.